This recording will go over multiple sclerosis, also known as MS. MS is a chronic disease caused by immune, genetic, and/or infectious factors that affect the myelin sheath and nerve fibers of the brain and spinal cord. A way to remember the pathophysiology of MS and what's going wrong is if you think of the MS for multiple sclerosis, think of the MS for myelin sheath. Myelin is responsible for the electrochemical transmission of impulses between the brain and the spinal cord and the rest of the body. Demyelination can result in slowed or stopped impulse transmission. So normally the myelin sheath sort of cover the neuron there, and when that myelin is damaged or missing, it affects nerve impulses. So a lot of times you'll hear it compared, myelin sheath compared to insulation around electrical wires, right? It helps the electrical current flow the way it's supposed to. Well, if that insulation, or in this case myelin sheath, is damaged, those electrical impulses don't get delivered the way they should. So multiple sclerosis is characterized by demyelination or loss of myelin sheaths, diffuse random or patchy areas of plaque in the white matter of the central nervous system is the definitive finding. Multiple sclerosis is characterized by periods of remission and exacerbation. So there's different types of MS. And certain types have periods where a patient is at their baseline normal function, and then they have an exacerbation or a flare-up where they then have the symptoms of multiple sclerosis. Some of the different types include clinical isolated syndrome, or CIS. It is an episode of neurologic symptoms often attributed to MS that last for at least 24 hours. About half of people who are diagnosed with CIS develop MS within 10 years. Another type is relapsing remitting MS. It occurs in most cases of MS, so the most common one we're going to see is relapsing remitting. The course of the disease may be mild or moderate. Symptoms develop and then resolve in a few weeks to months, and the patient returns to their baseline function. Another type is primary progressive. With primary progressive MS, there is a steady and gradual neurologic deterioration without remission, so they don't go back to that baseline. The patient has progressive disability with no acute attacks. Another type is secondary progressive MS. It begins with a relapsing remitting course and later becomes steadily progressive. So initially they keep returning to baseline between flare-ups, but over time become steadily progressive. So that's known as secondary progressive. And finally, progressive relapsing MS. Frequent relapses with partial recovery, but the patient does not return to baseline function. In terms of etiology, or what can cause MS, the cause of MS is very complex and involves multiple immune, genetic, and/or infectious factors, although changes in immunity are the most likely etiology. So immunity, autoimmune problems play a big factor here. The environment can also contribute. It's just as an interesting FYI, people experience the disease more if they are living in colder climates, including the Great Lakes areas. In terms of genetic or familial patterns, having a first-degree relative, such as a parent or sibling with MS, increases a person's risk for developing the disease. And also, women are affected 2 to 3 times more often than men with MS. We'll get into signs and symptoms in a minute. When looking at or getting a history for the patient, we want to ask the patient about a history of vision, mobility, and sensory perception changes, all of which are early indicators of MS. Symptoms are often vague and nonspecific within the early stages of MS and may disappear for months or years before returning. So it can be difficult for a patient with MS to get a diagnosis because those symptoms are so vague and they go away, the patient forgets about them. And doesn't think there's anything much wrong to follow up with a doctor about. You want to ask about the progression of symptoms. Pay particular attention to whether they are intermittent or become progressively worse. And then ask about if there's anything that makes the symptoms worse, such as fatigue, stress, overexertion, temperature extremes, hot showers, hot baths. Ask the patient or family about any personality or behavioral changes that have occurred, such as changes in mood, poor judgment, attention loss, and also determine if there's a family history of MS or any other autoimmune disease. In terms of physical assessment, signs and symptoms, your textbook does have a key features box. Some of the key features listed in the box include muscle weakness or spasticity, fatigue, usually with continuous sensitivity to temperature, muscle spasms, paresthesia or numbness and tingling, vision changes, diplopia, which is double vision, nystagmus, bowel or bladder dysfunction, changes in sexual function, cognitive changes such as memory loss, impaired judgment, decreased ability to solve problems and perform calculations, depression, dysesthesia, which is also known as the MS hug, is a squeezing sensation around the torso and often one of the first symptoms of the disease or a relapse. Difficulty walking, dysmetria or ataxia, the loss of ability to coordinate muscles or have muscle control. Vertigo, pain, itching, emotional changes. Less common symptoms, but we might see, include intention tremor, which means the patient starts to tremor or shake when performing an activity. Hypoalgesia, which is decreased sensitivity to pain. Dysarthria, dysphagia, difficulty speaking and swallowing. Decreased hearing acuity, tetanus, so problems with the ears, loss of taste, and finally seizures. In terms of lab assessment, there's no single test that definitively is going to diagnose MS. We're going to get a history and go off of symptoms, how the patient's presenting. They can do a cerebrospinal fluid assessment, and they're looking for elevated protein levels and white blood cell count. They could also do an electrophoresis of the cerebrospinal fluid, which would show increases in the myelin basic protein and the presence of immunoglobulins, especially IgG. From there, another thing they could do that is commonly done is an MRI of the brain and spinal cord. And what they're going to look for is the presence of plaques in at least 2 areas, and that would be considered diagnostic for MS. The textbook also mentions evoked potential testing, which is a non-invasive test used to identify impaired nerve transition along a nerve pathway. Priority problems for the patient with MS include impaired immunity. Now, if we think of MS as an autoimmune disease, you've had a recording on the meds. A lot of the meds are going to be immunomodulators or immunosuppressants, so they're going to turn down the patient's immune system. When they're taking those immunosuppressants, then they're at increased risk for infection. Other concerns are decreased or impaired mobility, decreased visual acuity, and cognition. You have a separate recording that you've watched addressing medications for multiple sclerosis. Just want to point out again, many of the meds used to treat MS are going to be immunomodulators or anti-inflammatory medications. So if you think about what's an important aspect of patient teaching regarding these types of medication, it's going to be things that the patient needs to be aware of to prevent infection. So avoiding large crowds, staying away from people who are sick, hand washing. Those are common NCLEX style questions that you see related to immunomodulators, immunosuppressants, anti-inflammatory meds, where the NCLEX wants to know that you understand that the patient's at increased risk for infection and what are the things that we're going to teach that patient. A reminder from the medications, there's sort of daily routine medications, but if a patient is experiencing an exacerbation or a flare-up of multiple sclerosis, a corticosteroid is going to be added to the regimen to try and calm down that flare-up. Your textbook also has an honorable mention related to medical marijuana, that can be helpful with symptoms. It also mentions that stem cell therapy is being researched as a promising treatment to manage MS to help decrease symptoms. All right, for improving mobility, what are we going to do for the patient? Obviously, we're going to get PT, OT on board, going to be working with the patient. Other things we want to think about, muscle spasticity is a problem, so the patient can have muscle relaxants ordered. You had a different recording related to that, but within the Med-Surg textbook, it talks about intrathecal baclofen. So baclofen you've learned about already, but intrathecal might be new to you. So that is when the patient will have a pump and the medication is delivered to the intrathecal space. So within the fluid-filled space between the brain and the spinal cord, it'll be delivered directly sort of to the spine, to the intrathecal space. Other things listed here, we want to make sure the patient avoids rigorous exercise, being in hot baths, being in hot temperatures, because the elevation of body temperature is going to cause a flare-up of their symptoms. Next, in collaboration with the case manager and occupational therapy, want to assess the patient's home before they're discharged and find out if they need any sort of assistive adaptive devices to help them with their mobility and make sure that the home is safe, free of clutter when they become discharged. We talked about the patient with MS has fatigue, but it's a debilitating fatigue, right? Probably something that most of us haven't experienced. So we want to talk to them about energy conservation, how to space out activities so they don't get so fatigued. And finally, speech language pathologists can be brought on board. If the patient is having problems speaking or swallowing, the speech language pathologist can help with that. For the MS patient with impaired cognition, we want to implement the same strategies that we use for our dementia patients. So using single day calendars, making sure they have written lists or written recorded messages, reminders, keeping things in a familiar place. For eye issues, if the patient's experiencing diplopia or double vision, and this could be double vision for any cause, the treatment would be to cover one eye at a time, and that would eliminate the double vision.